In early stage triple negative breast cancer, there has been quite a shift into the utilization of neoadjuvant therapy, even for patients with node negative disease. In my practice, often for patients with a tumor about 2 centimeters, if node negative, or with node positive disease, we would consider the use of pre-op chemotherapy, often anthracycline and taxane-based therapy, prior to surgery. There have been a couple of studies now that have reported a compelling path-CR advantage with the addition of a checkpoint inhibitor to that pre-op therapy. And there are data from the I-SPY study and others that have suggested improvement in path-CR. We do know that failure to achieve a path-CR is associated with a poorer prognosis, and we also have the ability to incorporate post-surgical therapy, such as adjuvant capecitabine for 6 months, in those highest risk patients with a subsequent improvement in overall survival. I think where we need to be a bit cautious is whether improvements in pathologic complete response translate to improvement in event-free survival at a later date. And we've just begun to see some preliminary data with the use of both pembrolizumab as well as atezolizumab at the most recent San Antonio conference in 2019. For example, there are some clear differences between, say, the Keynote study and the Michelangelo trial. The Michelangelo trial offered the addition of atezolizumab to nab-paclitaxel and carboplatin as compared to just nab-paclitaxel carboplatin alone. Patients went on to have surgery, and then they received their anthracycline on the back end. The primary endpoint of that study is event-free survival. So that's an important study that is powered to show survival, although those data have not yet been presented. A secondary endpoint was pathologic complete response, and it was shown that atezolizumab did not appear to increase pathologic complete response in the overall intention to treat population. When you looked at the subset of patients that had PD-L1 positive disease based on using that SP142 assay, the pathologic complete response rate was a bit higher, about 52% compared to 48%. And overall, those patients with PD-L1 positive disease performed better than those that were PD-L1 negative. But again, uncertain about the incremental addition of the checkpoint inhibitor in terms of path-CR. Really, my take-home message is that while these data are encouraging using path-CR as a primary endpoint, we really need to see the impact on event-free survival and balance risk-benefit when we're analyzing what could potentially be long-term immune-related adverse events such as endocrinopathies, balanced by what the ultimate long-term survival impact may be. I think in medical oncology, our paradigm has often been investigating new novel agents in advanced disease and then gradually moving those agents up as they are showing promise. And in checkpoint inhibitors, it is following that same pathway. So we have compelling data from metastatic triple-negative breast cancer with the incorporation of a checkpoint inhibitor to backbone chemotherapy. We've now started to see neoadjuvant data suggesting benefit in terms of path-CR and perhaps event-free survival, but we await final data there. It naturally follows to begin to explore using these agents in the adjuvant setting to see if we can cure more women of this disease. And so one trial, for example, that is going on right now is in PASSION 131, which is looking at a randomized study, looking at a backbone of anthracycline and taxane-based chemotherapy with a randomization to a year of atezolizumab or not. And again, these studies are now powered for long-term survival, and that is ultimately what we're trying to help achieve for our patients. And so those studies are, I think, important, and we look forward to seeing those results. I am certainly hopeful that we can be able to refine which patients will benefit from these therapies and know with whom we should escalate treatment, and perhaps we can find a group of women that do not need escalation of therapy and can have a simpler approach.